Good evening, friends. So today we'll be talking about pheochromocytoma. So pheochromocytoma is basically the tumor which occurs in the adrenal medulla. So if you see 90% of the cases, there will be a tumor in the adrenal medulla, whereas in 10% of the cases, there will be a tumor in the abdominal sympathetic ganglion, and such type of pheochromocytoma is known as catecholamine secreting paragangliomas. You can see over here. Right. Now we'll talk about the clinical features. So it occurs equally in both male and female, and the diagnosis is made mostly in the fourth or fifth decade of life, and 90% of the cases it occurs within the adrenal medulla. So since it occurs in the adrenal medulla, there will be increase in the catecholamine secretion, and in 10% of the cases it is malignant and occurs in the abdominal sympathetic ganglia. Now we'll talk about the clinical features in detail. So first, if you see, there is headache, right? So why is there a headache? Because uh, of the increase in the secretion of the catecholamines, epinephrine, norepinephrine, they are increased. So this causes an increase in the intracranial pressure and leading to headache. And because catecholamines are increased, epinephrine, norepinephrines are increased, there will be hypertension. And similarly, there will be palpitations and chest and epigastric pain. Dyspnea refers to breathlessness or difficulty in breathing, and dizziness will be there. Diaphoresis, difficulty in sleeping, and nausea and vomiting will be there, and there will be sensation of anxiety and fear because the sympathetic activity is stimulated, and since the sympathetic activity is stimulated, there will be even tremors. And why is there pallor? The reason there is for pallor is because of vasoconstriction. The blood flow to the cutaneous blood vessels will be reduced. So because of the vasoconstriction of the cutaneous blood vessels, the blood flow will be reduced, so there will be pallor, anemia will be there, right? So there are even some chronic complications also. So now we'll talk about the tests that are done for diagnosing this particular disease. So the tests include, there are three types of tests, okay? Basically biochemical test, pharmacological test, and imaging diagnostics. So first we'll talk about biochemical test. So if you see in biochemical test, there is first there is triglyceridemia. That means there's increase in the triglycerides. You can see there is lipolysis of the free fatty acid, because of which VLDL synthesis increases, and LPL activity increases, because of which there will be triglyceride breakdown will be there. So this leads to hypertriglyceridemia. Now since catecholamines can also suppress the insulin secretion, there will be hyperglycemia as well. And we know that all these cells will have the LDH, that is serum lactate dehydrogenase. So because in this condition there is tissue hypoxia, anaerobic metabolism will be taking place, muscle damage will be there, and there will be eventual release of LDH in the blood, right? So that is the third condition. And fourth, you can see that there is increase in the metanephrines and normetaphrines. So basically when epinephrines break down, there will be metanephrines and normetaphrines, okay? So that will be released. So this can be diagnosed, okay, by or they can be screened using HPLC and tandem mass spectroscopy, right? So these are the biochemical test. Now we'll talk about the pharmacological test. So in pharmacological test, we have the Clonidine suppression test. So basically we perform pharmacological test only when the patient is having all the symptoms of pheochromocytoma, but the biochemical test fails, right? So all the biochemical test is negative. So basically if a person is having a positive biochemical test, then pharmacological test is not necessary. So we perform pharmacological test only when the patient is having the symptoms of pheochromocytoma, but the biochemical test is negative. So in pharmacological test, we have a clonidine suppression test. So here basically we give an oral dosage of clonidine. So this clonidine basically suppresses, okay, it's actually an alpha 2 receptor antagonist. Alpha 2 receptor is an adrenergic receptor. So when adrenergic receptors are when something acts against adrenergic receptor, catecholamines, that is epinephrine, norepinephrine secretion will be reduced. So but in patients, okay, like you may ask, like how much is it reduced? So the answer is less than 500 picograms per ml, okay? So if you administer clonidine to a person, like through orally if you administer, it is an alpha 2 receptor antagonist. So what will happen is the catecholamine secretion will be reduced. So the norepinephrine level will be less than 500 picogram per ml. This occurs in normal individuals, okay? But if a person is so suspected to have pheochromocytoma, in those patients the catecholamine release will not be suppressed, because in those patients there is pheochromocytoma. Like in the patients who is having pheochromocytoma, the catecholamine release will not be suppressed, right? So that is the basic of this clonidine suppression test. Thirdly, we have imaging diagnostics. So this is basically used to locate the tumor, right? So we need to locate the tumor, like from where it is originating, or the course of that particular tumor, in order to plan properly for the surgeries or surgical interventions and all. So basically, we perform CT scan and MRI normally, and but in patients who are not supposed to be exposed to too much of radiations, like in pregnant women and children, we prefer ultrasound. Right, so this is basically done only after the catecholamine excess is confirmed. Like only after the catecholamine excess is confirmed, we perform imaging diagnostics. Right, so these are the three tests we do: biochemical test, pharmacological test, and the imaging diagnostics. So that's all about pheochromocytoma. Thank you.